Universal healthcare's ugly side. Healthcare is a line item on a government budget. President Obama's signature legislative achievement was the Affordable Care Act of 2010, the ACA or Obamacare. During the debate leading up to the creation and vote for the legislation was the question of the establishment of death panels. The mainstream media and Democratic establishment obediently declared that these death panels were not a thing, and that talk of that was a conspiracy theory meant to scare people from supporting the ACA. Though the name death panels was an overly dramatic name meant to elicit negative response to the legislation, it was in fact based on a trend being seen in other Western countries that had adopted some form of universal health care. The current model for the healthcare in the United States is through private insurance that is contracted by the employer and are part of the employee compensation and benefits. The U.S. has insurance companies contracting with healthcare providers to form networks and negotiate costs for health services and to provide deductibles for the insurance holders. Most health insurance in the U.S. is what's called self-insured and accounts for 2/3 of the health insurance provided to Americans. Though an expensive system, and sometimes too expensive for some Americans with economic hardships or a terminal disease, it is the primary role is to provide the consumer with health care options. It is not a perfect system, but it has benefits not found in other models around the world. Most countries in the world use some form of universal health care. The first issue with universal health care is that the care is part of a budgetary process for government expenditures, like any other government program such as defense or transportation. This means that there must be a funding mechanism from the government in the form of some sort of tax. The other factor is that when budgets are tight, a decision must be made on how to manage healthcare costs in the same manner as other government departments. This leads to rationing of care to make sure that the department has the funds to cover both fixed and variable costs for the budgetary year. Rationing can take many forms, such as reducing staff or increasing wait times to slow the expenditures from the budget. This leads to pushing procedures into the next budget year, or patients give up waiting and forego health care, and in some cases pass away before care is received. This is a common issue. A newer solution to rationing is based on hard economic realities based on actuarial analysis. An example is that a person who is retired needs a hip replacement that will cost more than what the person is expected to pay in taxes or produce for the economy in their estimated remaining lifespan. This may lead to a determination that the cost of the care is more than what will be given back to society by the patient, so health care is refused. This happens despite the person paying into taxes into the system their entire life. In the same scenario, if the person was young and beginning their work career and needed a hip replacement, they would be granted the operation because they would be expected to pay more to the system and create more output in the economy in the future than the cost of the operation. It is now commonplace for countries with universal health care to adopt such practices to keep variable costs down, but sometimes that's not enough to healthcare expenditures continue to grow due to increased cost of drugs, healthcare technology, labor costs, aging population, demographics. The new trend that created the death panels discussion is the legalization of state-assisted suicide. This was originally intended to reduce end-of-life suffering of people at the end of a stage of a terminal condition, but like many government programs, the justification for the legislation would find other uses for budgetary constraints. This apparent sympathetic approach to relieve the suffering has created new pathways for state-assisted suicide for people who are not at the terminal phase. In Canada in 2016, the country expanded state-assisted suicide to include people with terminal diseases but have not reached the end-of-stage part of the disease. This new expansion included doctors and counselors' guidelines to have these discussions with people with the terminal disease as an option. The new rule and restriction was that death from the condition had to be foreseeable, but not necessarily imminent. The law in Canada was once again amended in 2021 with the provisions that the option for state-assisted suicide and associated counseling service could be offered for conditions that death from an illness was eventually likely, but time frame was unforeseeable, but it was also expanded to include mental health conditions. The definition of a mental health condition is open and includes depression, anorexia, anxiety, but for the most part, the mental health conditions are not defined, but are left up to the panels of medical professionals to ensure that the patient has to have the mental capacity to make that final decision for state-assisted suicide. The mental health aspect went into effect in 2023 after a 2-year delay. It does not take a lot of imagination, even with the assurances of the creator of the panels, that this cannot be subject to abuse. State-assisted suicide has jumped in Canada since the law was updated in 2021, and continues to grow. It is now the 6th leading cause of death in Canada. If the medical system is being pressed for resources, it could easily be seen that the administration and government officials will press the issue in state-assisted suicide to reduce the long-term budget costs of care of terminal patients that are not near death. And the mentally ill, who though may not be taking up a lot of resources, are not contributing a lot to society economically. Will the definition of what is considered a mental illness be expanded to allow more people to be eligible for state-assisted suicide counseling? The death panel warning in 2009 all of a sudden are not a conspiracy anymore. Is this logic a leap? Probably, but it's more than the leap of the original conspiracy theorists of 2009 that warned of these panels. The idea of providing everyone with health care and providing services to reduce suffering would sound like a virtuous goal that people can easily rally around. These good feelings cannot make up for the fact that even in socialist countries, nothing is free and programs must be paid for and funding mechanisms must be created. The example of Canada is that these government programs grow and the costs increase. There is a motivation to cut costs. The difference is that this is not about a government bureaucracy deciding whether to add a new road sign to a strip of highway, but it's almost about impacting people's health and well-being into a government budget. Using logic-based budget gimmicks and cost reduction programs are just asking for abuse. This is especially true if the bureaucrat is being measured on how they control costs and manage budgets. These are the people that really manage healthcare in a universal system and consider people as subjects to be managed and not citizens of a free society meant to protect their rights.